Everyone should have a prompt that they have to accept. Okay. So again, recall a lot of what we went over for this first part of the material was subjective and objective data. So somebody let me know what subjective data is.
Information from the patient.
Yeah, I love that. That's a good summation. So it is information that's coming from a patient, and this patient, it's going to be their observations of what's going on with them. All right. And then somebody let me know what objective data is.
Observe facts.
Very good. Observe facts from professionals. So I love that. So if I were to tell you, my feet have been tingling for the last week, subjective or objective?
Subjective.
Subjective.
Subjective. Very good. What about the patient's blood pressure is 128/72?
Objective.
Objective. Very good. Very good. All right, so you get how the game goes. All right, so let's shift from subjective objective, because we're gonna circle around it a couple of times. Let's shift over to types of assessments. Okay, so someone give me an example of a screening assessment.
A health fair to check for cholesterol and blood pressure.
A health fair to check for cholesterol and blood pressure. I love that. That is a screening item. That is a screening assessment. Good. Someone tell me what a comprehensive assessment is.
Head to toe.
A head to toe. Very good. A complete assessment is also known as the same thing. Tell me what a problem-based or a focused assessment is.
For a specific problem.
Okay. So name a specific problem that could happen to a person that would be warranting a problem-based or focused assessment.
Like ear infection, maybe, or a UTI.
Sure. Ear infection. Somebody's acting weird. We find out they have a UTI. Someone's reporting difficulty breathing. Someone's reporting acute chest pain. We need to do a focus assessment to find out what's going on. Perfect. What's a follow-up assessment?
To assess if the interventions you applied were effective or ineffective.
Oh my God, who was that? I'm not on the screen, sorry. That was BEAUT full. That is exactly it. So a good example of this would be a pain reassessment. I'm doing a focused follow-up assessment to make sure that their pain is alleviated, or that we're getting at least closer to their pain goal. And if we haven't, then we might need to do intervention. Very good. So I need for you to understand the difference in all of those. And I need for you to understand that if I were to say, I am collecting blood pressures and cholesterol levels at a local YMCA, you would then say that the type of assessment that is most synonymous with would be
Screening.
screening. Very good. Yeah. And if I were to say someone reports difficulty breathing, what would that be?
Problem-based.
Problem-based.
Thank you. Very good. Do you guys know that you've already answered 28 questions for me? Do you know that? We are 7 minutes into this, and you have already answered 28 questions. Not that are necessarily on the exam, but in general, 28 questions you've answered for me successfully. This is what I mean by learning a whole lot by learning nothing at all. It's trickery, right? You guys really don't even realize how smart you already are just by doing a very little bit, instead of banging your head against the wall trying to figure out some concepts that take a long time. Just relax. I'm telling you, you guys are really smart. All right. So let's talk about data collection. If I have data sprout about all in front of me, all right, the next logical step I'm going to take when I see information on a patient sprawled about, this one's imaging, this one's labs, this one's coming from this hospital, that one's from that hospital from 10 years ago. What do I need to do to all of this data in order to have a complete assessment of the situation?
Cluster?
Cluster that data. Yes. If you have data from 10 years ago, that data is just as important as data that you have from 2 weeks ago. It just depends on the circumstance. If someone has a history of CHF for 15 years ago, that is going to let me know why they're having these chest pains, because again, they're declining even more. Maybe it's time for a pacemaker. Maybe it's time that we have to do transcutaneous pacing to keep them alive until we can get them on the table. Okay, so cluster that data. Perfect. All right, now let's talk about prevention, primary, secondary, and tertiary prevention. Tell me what primary prevention is.
To prevent something from happening, not getting it,
Good. Give me an example.
like exercising.
I love that. How often?
Like 3 times a week.
3 times a week.
Good. What else?
Balanced diet.
Vaccinating,
Yes. Balanced diet. What else? What's the classic example?
Flu vaccine.
vaccines,
Vaccines. Yes, I love that for you guys. It's so smart. All right. Tell me about secondary prevention.
Ketchup.
To keep something from getting worse. You have it, but or it could be turned around. Something about turning something around.
Oh,
Like
good.
that type
Yes.
2.
Let me explain that. And that's really good. And I thank you for telling me that you were having a little trouble with that, because it is kind of wonky if you think about it. So here's the best way to define this. I am overweight. So like after I had Athena, who's, almost 2, I gained like 110 pounds because I really liked eating cake for breakfast. And I mean like the whole cake, right? So I became a borderline diabetic. So as soon as I had baby, I was no longer a diabetic because I quit eating cake every day, because I quit desiring cake every day. And then I lost all my weight, and then problem solved. That would be a secondary preventative method through diet modification. Does that make sense?
Mhm.
So I was a borderline diabetic. I fixed the problem. I retroactivated it, which is a huge word that you're going to hear in medical, which basically means I turned it around. I did a 180. We're all good. And then that's secondary prevention. They use examples like that specifically in exams. So just be aware of that, because secondary prevention can get a little cattywampus. So give me some examples of secondary prevention. I just gave you one. Give me another one.
Would high blood pressure be one? Would that be one?
High blood pressure, when it becomes a problem to the organ, aka the kidneys, that is when it becomes a problem in the tertiary perspective. The second I have organ damage, I become tertiary. I'm no longer secondary. So blood pressure, it depends. Do we have organ damage? Does that make sense?
Right. Okay. Okay, what about a heart attack? Did you add up with something like heart attack, but then
Heart
you
attacks. Good. Here's the caveat with heart attacks. Heart attacks, if you do a low dose aspirin to prevent further heart attacks, that is considered a secondary modality of prevention, because we're preventing it from happening again. A heart attack is something that is life-changing, but albeit temporarily if it's a small heart attack. Does that make sense? So I can have a mini stroke, which would be the equivalent of a non-STEMI. Does that make sense?
no.
It doesn't, does it? Because it sounds very serious. When you get into the medical world, you'll realize that heart attacks are a spectrum, much like strokes are a spectrum. I can have a stroke and it not be a big deal or phase anything about it. But as long as I'm doing my low dose aspirin, I won't have another one. So that would be my tertiary or my secondary prevention, and taking that aspirin so that I don't have a tertiary problem, which is a massive heart attack, which gives me lifetime damage. Does that make sense?
Right. Okay, so you're doing something to, well, the first one, like the exercise, you're doing some preventing. So then also with the secondary, you're also, you had it, but you're doing something again to prevent. It's kind of like, I don't know.
To prevent it from being permanent.
Okay.
It's kind of like an NFL player when they get a concussion, right? And they get knocked out, they say, hey, you get knocked like that again, and you're going to be brain dead. And that's your warning. That's secondary versus tertiary. Does that make sense?
Right.
Like you're on the lip and you're going to fall left or right, but right now you're on the tight wire and you better figure it out. That's secondary prevention. So heart attacks, making sure you take that low dose aspirin after you're done. Doing annual mammograms are a big deal, right? Because could we have breast cancer? Yeah, we could have precancer cells. Are we going to know if we don't do that annual mammogram? No. Completing a monthly breast examination is another one, or completing a testicular examination is another one. Could I have something? Yes. Am I going to find out if I don't do it? No. Does that make sense?
What would
Yeah,
you say wound care is like it? Because it could be organ damage if you're down to the bone, right? But then
So
if
that's
you're
integumentary damage. Sorry to interrupt. That's integumentary damage, which is organ damage. So a wound would be considered organ damage
so it's
because
tertiary.
yeah, your tissue is going to be a big deal because if we dip into that tissue and get deep enough, we get septic from wounds. So that's definitely a problem that can kill an individual very quickly. So that would be a tertiary perspective. Yeah, so wound healing would be a big deal. We know those wounds aren't going to heal. We're trying to heal them as best as we can and give the patient quality of life as best as we can. Does that make sense?
yeah. I have one question.
Sure.
Um, this is probably a stupid question, but is it so secondary? That's including like pharmacological intervention. So it's not just habits. Basically, it's habits and then possibly some medication. But it's just as long as the tissue or organs haven't died or become necrotic or anything like that.
That is correct. When I am insulin dependent,
Okay.
that is organ damage. My pancreas is never going to work again. So what I
Gotcha.
could
Okay.
do is
Thanks.
I could take glipizide. I could take that, which is metformin or the derivative of. I could take that in hopes that that's going to fix my sugar problem, concomitant with dietary management of my sugar, my physical sugar intake. That's secondary. Tertiary is insulin. Tertiary is that pancreas is never going to get better. I'm stuck on insulin. Does that make sense?
Yeah. Thank you.
I'm trying to manage that insulin at that point so that I don't go into DKA and that I have as normal of a life as possible with as little tissue damage as possible. That's the end goal with tertiary prevention. Okay. So now that we've talked a lot about tertiary prevention, give me some examples of tertiary prevention.
Like damage to the liver from drinking.
Okay, so from a tertiary prevention perspective, how could we help that patient that has end stage liver disease? It can be done. Just think creative.
Well, they would have to stop drinking.
I think that's great. Education on stop drinking is tertiary prevention because it is going to lead to better outcomes of that patient overall. I love that for you. Learning how to deal with a chronic problem like asthma or arthritis. These are also good examples of tertiary prevention. Participating in cardiac rehab post massive heart attack. Notice I said massive heart attack. So when you go to cardiac rehab, they teach you about low sodium diet, 2 gram or less. They teach you about the DASH diet and what that looks like. They teach you about making good exercise regimen changes, right? Things of that nature. They talk to you about coping in stress and development of the mental health system. things of that nature are tertiary because it is not going to fix the problem, but it will give me a higher quality of existence while I'm still here. Does that make sense?
Dialysis will be one.
Dialysis is one. Electing to have dialysis procedures is considered tertiary because am I going to get those kidneys back? No. Am I going to be able to have a filter to my blood so that I don't have hyperkalemia and die? Yes, absolutely. So that's tertiary. Good examples. Do you guys feel comfortable with that?
Oh, I think once I see the questions, it'll be more in depth, hopefully. But
We'll do it. I feel like since tomorrow's the first exam, I always give everyone a little bit of what I call like a speed race. So I will go over the hard concepts that I feel like we need to go over one more time. I'll do that tomorrow, maybe 20 minutes prior to the exam start. And I call it doing drills just to kind of get your brain right in the right mind frame. Does that make sense? So you can drop whatever's going on outside for long enough to pay attention and get your brain in the right track. It's going to be okay. It really is. I promise. All right, let's keep going. All right, so let's play this subjective objective game, okay? So, client's skin is moist, pale, and dusky.
objective.
Objective, good. I'm a nursing professional. Sorry, you guys have to hear me squabble. I have not been sleeping for the last 3 months.
Subjective.
Objective.
Subjective. I'm dealing with my asthma just fine.
Subjective.
Subjective.
Okay, good. Patient has mastectomy from 2017, right breast.
Objective.
Objective. I love that for you guys. So smart. Perfect. Okay. Let's talk about different types of the interview process during an assessment. Okay. So the assessment is the big thing that we do to figure out what's going on with our patient. It's the complete head to toe. And part of the interview we go through is like an introductory phase, and other parts are symptom analysis related, and other parts are summary statements. So very quickly, someone tell me what an introduction phase is. What does it sound like? What are we saying?
Getting to know the patient.
Yes, getting to know the patient. Perfect. So how do we do that?
Reviewing the chief complaint.
Good, but remember, we're people.
And
so the first thing that we
Introducing
do
yourself.
introduce ourselves. Beautiful. Don't forget who you are. You're the boss. You're the one running the show, right? Like everybody knows that. So you walk in the door and you say, "Hi, I'm Molly. I'm your nurse today." And then right after that should come out of my mouth, what?
Tell me what's going on.
I like that. I'm here to learn about your pain that you're experiencing. I'm here to learn about what brought you here today. That's a common one. Perfect. So that is your introduction phase of I am me, you are you. I'm here to understand what you're doing here. I'm here to understand about the pain you're experiencing. Very good. Perfect. All right. Let's talk about symptom analysis. Ask me a question that would be in the category of symptom analysis.
What symptoms are
Yes.
did it
What
start?
symptoms are you feeling? What else did I hear?
how long
Have you experienced those symptoms?
Yes, yes. Okay, both of you guys are saying the same thing. So yes, can you describe the pain that you're experiencing? Can you tell me what leg that you fell on? Right? This is symptom analysis. This is breaking it down to find out what the problem is. Perfect. Now, let's talk about a summary statement. What is a summary statement?
All the data you then collected from the patient, and you summarize it far as
A recap of the visit.
It really, nursing friends, nursing really is common sense. It's a statement about summarizing everything that you've talked about. So let's say that I'm asking about this patient and their pain that we've been talking about. I would say, hey, listen, I hear your pain is everywhere. Is that right? Because you just told me it's in your head, it's in your elbow, it's in your right great toe, distal phalanx. Like that is what I know. And I'm just understanding it's kind of everywhere. Is that accurate? That is the summarization statement. That is, hey, listen, what I'm getting out of this deal is that it's all over. Is that cool? Is that accurate? Perfect. Perfect example of a summary statement. Also, summary statements are right before you're about to walk out of the patient's room. Always do a summary statement. Always say, hey, listen, I know that you have pain everywhere right now. I'm going to go get pain meds. Do you want the hydrocodone or the hydrocodone, or do you want, I don't know, the hydromorphone? One is a PO pill. One is a get her done IV push. And I always, validate that they can have that medication at that time. I jump out of the room. They know what I'm doing. It saves so much time to give them a 30-second summary statement to let them know what you're doing and also let them know the expected time. This is a good opportunity to tell you, let your patients know what you're doing outside of your rooms. They will call you less, and your ratings on your customer service is going to be the highest, and no one's going to ever know why. And they're going to be so mad at you. And all you're going to have to do is just be you, right? Just be smart, work a little bit ahead of yourself. All right. So summary statement, you got that down. Now let's talk about things that are going to be responses to let our patient know that they have assumed a reflective technique, and I have understood that, and I am able to then let them know what it is that they're saying. So here's the example. I have a patient that tells me, I guess I eat okay. And I say, all right, cool. How much she eat in a day? And they say, I don't know, like 2,800 calories. Now, using a reflective technique, how would I then let them know that I've heard what they've said?
You'll repeat back what they said, repeat back what they said and be like, if I heard you right, are you saying you eat 2,800 calories?
I flip and love that. You know why? Because again, nursing is common sense. If it's called a mirroring technique and it's a use of therapeutic communication, that's your answer. You literally just roll it back at them. Did I understand that you said you eat at 2,700 calories a day or whatever I just said? Absolutely. Perfect. How are you guys feeling right now? Is everyone feeling pretty good right now?
Yeah, I am so far.
Are we
Yes.
feeling good? I'm so sorry, guys. Okay. Now let's go into bigger issues that sometimes patients have to talk to us about, and we have to really get serious. So if someone tells me that they've been feeling depressed lately, or they've been feeling like they don't really have any belonging in this world, what would be an open-ended question that I can ask them to probe into that without getting offensive to somebody or shutting someone down?
What else have you been feeling?
Can you tell me more about it?
Ooh, who is that? Who did the tell me more about it? I like the, can you tell me about what you're feeling? I like that. Tell me more about that is better, slightly. I don't even want to use the word better, more appropriate, slightly, but here's why. Tell me more about that doesn't insinuate that that's exactly what's going on in their brain. Tell me more about that says, hey, listen, I want to get this right. I am not going to put myself in this situation, and my brain and my emotions and what I'm feeling for you is not in play. Tell me more about what you're feeling so that I can slip into your shoes and step into your vibe. Does that make sense? So, although the first one was really good, that one was slightly more accurate for that reason. Very good, though. All right. So, if I am telling you that I'm having symptoms that are persistent and have lasted weeks, I have a massive headache that's just been going on for weeks. What is an open-ended question that you need to ask me, because this could be a big problem for a lot of different reasons. So what's one question you can ask me that will delve into this, a very broad statement or question, if you will?
What are the symptoms?
What other symptoms have you noticed?
Yes. What other symptoms have you noticed? If I have a patient who has a persistent headache, does anybody on God's green earth know what I'm worried about?
Like a blood clot somewhere.
Ooh, we're stepping into some good territory right there, friend.
High blood pressure.
Oh, I heard high blood pressure. We're stepping into some good territory, my friends. The number one comment that people have when they start to get hypertensive and nearly into an aneurysm, which gives them a subarachnoid hemorrhage, or a traditional lacunar infarct, which is a destroyer of air because of a blood clot. Yikes, all you guys hit it all together. These are the beginning signs. Is a persistent headache for weeks. These will kill you almost instantly. We're talking about a massive infarct, which is a lack of oxygen to the brain, or a subarachnoid hemorrhage, which will give you a midline shift. Your brain will squish to one side of your head and you'll become comatose nearly within a matter of a day. So those ladies that shouted all that out, like bonus star, that was amazing. What other symptoms have you noticed? That's how we figure that out. If their other symptoms were, it was weird. I like had this pinch in my head and I felt like my brain was going to explode, and all of a sudden nothing. And then now I'm just having these kind of weird, dull headaches. Dude, that's a hemorrhage. Dude, they had an aneurysm blow and it's not a big enough leak to kill them. That's a big deal. Do you see what I mean?
Mm-hmm.
Good job. All right. No matter what, the data that I collect on my patients, above all, has to be what?
Accurate.
Accurate.
Accurate. Thank you. Thank you. Do I tell on my report what my opinion of somebody else is?
No.
Do I ever say girl had RBF and was giving me stank face?
No.
No. I had a nurse that said that someone was acting the fool, in quotations. I'm not even playing. Put it in their data bank, and I had to have them redact that, because if they didn't, they could have gotten into a lot of trouble. Because who knows if that person was really feeling that? Like, and plus your patients can see their stuff now that you're typing in. As of April 2019, 2020, that became information they could see, just like any other information they can log into and get a hold of. So it's got to be accurate. Don't lie, because it's going to come back and bite you in your tail. And don't tell them they're acting like the fool, in quotations. That's just dumb. Oh, side note, if someone is cussing you, are you allowed to put that in quotations when you're documenting?
No.
Yes.
Oh,
Yeah.
you better. Every
Okay.
last word. Every last word. Those are really fun to read too. It's really fun to read too. I'm just saying. All right. Human trafficking. You guys know it's a big deal to me. You guys know it hits near and dear. So tell me about victims of human trafficking. How do they present? What's different about them?
They
No
always
eye
have somebody,
contact.
Ooh, I heard a lot at once.
someone accompanying them.
Someone's accompanying them and they answer for them.
Mm-hmm.
Yes. What else?
No eye contact.
No eye contact. Demonstrates fear, nervousness. Yeah.
No address.
No
No
address. No cards. No identification. No nothing. Good. So smart. Thank you. All right. Let's go back to assessment, because assessment is going to be a big deal for this exam. So we have sub assessments and we have core assessments. Now, tell me what a core assessment is versus a sub assessment.
A core assessment is just doing a regular exam over the skin. And a sub will be like somebody you're not checking in between the toes like a diabetic. But if you know they're a diabetic, you're gonna go check that particular area.
That is literally the best answer that I've ever heard anybody explain for this concept. And I might just steal it from you. I'm just letting you know. That was really good. That was really great. So that's exactly it. The core assessments are the ones we're going to do for everybody, no matter what. I'm always going to auscultate lung sounds. I'm always going to auscultate heart sounds. Those are core assessments. My sub-assessments are going to be assessments related to what is developing with my patient. So if my patient comes in with, I don't know, pneumonia, then my obvious core assessment is going to be the lungs. And then my sub-assessment is going to be their assessment on, I don't know, the use of their incentive spirometer. Does that make sense?
Mhm.
Okay, cool. Is this helping you guys?
Yeah.
Yes.
Yes.
Okay. I don't want to bore anybody. I'm not saying anyone sounds bored. I'm not getting, this is an interactive opportunity. So I like to hear different voices, but I also know you guys are tired. So do what you can do, but just pay attention. So long as you got that, we're good. All right. And if I am boring you, please let me know so that I can not, because I hate that. There's nothing worse than being in
No,
class.
I'm excited for it.
Cool. So let me give you a scenario. And this is a very basic scenario, but this one comes up enough. If I'm taking a patient into the room and they go into the room and immediately they're sweating bullets and they're fine otherwise, but they're, wafting their shirt and they're acting weird and looking around. What's wrong with my patient? What do I naturally need to do?
Ask them how they're feeling. I know it was like adjust the temperature instead of just.
Check their blood pressure and blood sugar.
I like blood pressure and blood sugar, sure. But if you feel that it's something probably not that immediate, perhaps the room is very warm, then we would simply just adjust the temperature to reflect the surroundings they need in order to give them an appropriate assessment. Now, if it's freezing in there and you have to do an abdominal assessment, what do?
Drape
Cover
them.
them up.
Yeah, drape them, cover them up, drape them only as far as you need to drape them, or keep them draped unless you have to pull it back, and only pull back as far as you need to pull back. Absolutely. Again, this is your health assessment class. You guys are trying to jump the gun with really simple, like hard concepts. And I see you guys do that, and I think it's amazing. But remember, the small stuff is important too. Don't forget the small stuff. It'll bite you in the bullet on exams. All right. Let's talk about cultural backgrounds. Now, there's lots of them. Are any two the same?
No.
No.
So what do we need to understand as nurses first and foremost about any person that's going to be in front of us, no matter what their cultural background is?
Treat everyone as individuals.
Yeah, you need to treat them as individuals because guess what? They are. All right, no matter.
Unique.
I'm sorry?
No, I was saying they're all unique. Every individual is unique.
That is correct. Yeah. And that's why we are moving towards a more holistic approach for medicine and for nursing and for education. I got a lot of comments that everyone keeps telling them to calm down, and it's weird because it's such a weird transition from like straight up science to like straight up medicine. It's bizarre, so it's affecting a lot of people. I literally see the same thing every semester. This is normal for you. You guys are transitioning. It's okay. You're doing a really good job and you should be very proud of yourselves. I'm very proud of you. I hope you know that. So, digressing back, no two people are the same. They are all unique. We create a holistic approach for their care and will continue to do so. So, very good for that. All right. Talk to me about conducting interviews with a patient and building a positive rapport. How do we do that in an interview phase while we're talking to these patients? What do we need to do to show them that we are trying to establish a positive rapport?
Active listening.
Active listening. I love that. What else? Do we look at them?
Yes.
Yes.
Do we express attention by shaking our head when they're talking to let them know that we're engaged?
Yeah.
Yes.
I told you that nursing is common sense, and sometimes it's so silly, it's almost unbelievable. Okay, this is how I'm tweaking you guys to think, because you think I'm playing games over here. I'm not. This is really the building blocks of what it is. So you have to express attention to them. You have to engage with them. You have to show interest with them. Things you don't do that we see in nursing, which is why we make these test questions. We see them back to the patient typing on a computer. Is that smart?
No.
No, it's dumb. It's rude. It's so rude. Can you not write it down on a piece of paper while you're sitting there looking right at them? Of course you can. Could you just remember it? Yeah, there's that. Do you laugh at them when they're crying?
No.
Oh,
Right? Like you guys know what to do. Very good. All right. Open-ended, closed-ended. How many drinks do you have in a week?
That's close.
That's a close.
It's closed because you're just going to give me a number and we're going to move on. Good. What does the pain feel like?
Ended? Close ended?
That's open.
and
That's open-ended. What does the pain feel like? It feels like somebody's stabbing me. It feels like, I don't know, I got punched in the teeth. I can answer that a million different ways. Very good. Do you have someone to help you at home?
Close.
Close. It's yes or no.
No.
What typically helps you get to sleep?
Open?
open-ended.
It's open. Yeah, for sure. What methods have you tried so far to help with your problem?
Open.
Open.
Open. That one often as nurses. Are you in pain at all right now?
Closed.
Closed. Very good. All right. Let's play the game of, am I giving good therapeutic communication? Here are your options. Option A. Sorry, sir, you seem to have had a CVA and an MI.
Non-therapeutic.
Okay, cool.
Not.
Not therapeutic. Nope. Why?
Because maybe the way you said it.
The terminology.
The terminology. I love that for you. The average person in Ohio has a 5th grade reading education.
Okay.
So are they going to know what a CVA and an MI is? Do you know what a
No.
CVA is, Drew?
No.
Yeah, stroke and
Cerebrovascular accident. So like a lot of people don't know that. So yeah, that's why. You should just do what I say.
non-therapeutic.
I swear to God, I've heard nurses say that. I swear to God, I have. It drives me nuts. So I get stupid. If you guys hear that, you guys get stupid too. You have my full permission. You can use the D word and say, I told you so. Let's see. Why aren't you going to your follow-up appointment like I told you?
Non-therapeutic.
Thank you, because I'm walking out of that room, but not before I get an assault charge, because I'm thumping you on your forehead for acting that way. Absolutely. All right. What about when was your last flu shot?
Therapeutic.
Yes, therapeutic. Good. All right. When we're dealing with people in the elderly population, how do we have to work with them differently to conduct any type of interview and or assessment?
Give them time.
I have to speak slower.
You got to give them time. You got to speak slower. How do we speak to them if they have a history of a hearing problem?
Face contact.
Look at them in the eye.
Interpreter.
Direct. What is it? Facing them. Something like that.
You turn the TV off. If there's a TV on, you turn it off.
Yeah, if there's a TV on, you turn it off. You want to promote a nice, quiet environment. elderly people, do they hear better low frequency
Yeah.
or high frequency?
Mhm.
High frequency.
Low.
Low
Low.
frequency.
Is it
Low.
low?
Low frequency is what they hear
low.
better. They lose their ability to do high frequency. I always use the example, and I know some people don't like me using examples, but trust me, this one's a good one. You'll never forget it. In nursing school, I was kind of a habitual line stepper. I don't know if you've noticed that or not. That was a joke. So I thought it would be funny when I learned that old people can't do high frequency stuff. And one of my favorite professors, she was an older lady, and I put maybe a bad phrase on a very high frequency level, and I put on a PowerPoint slide and ran it and looped it for 3 hours and played it the entire time in class, and everyone laughed except for her because she couldn't hear it. So now you know high frequencies, you could literally drop the F-bomb for 3 hours and they can't hear it. Low frequency, you better watch yourself. They're going to hear you just fine. And now you'll be happy I told you that story tomorrow when you find out why. So boom, there you go. So we need to give them more time, and we need to talk not at a high frequency level, at a lower frequency level. And we do that by not speaking too fast. We want to enunciate, but we don't want to influx our lips and speech so arrogantly that it's incomprehensible for them to read your lips. Does that make sense?
Mhm.
Easy enough, right? So let's talk about coming into a room at a bad time, because this happens sometimes. I'm going in to go do an interview for this patient. I am a wound nurse, right? When I come in, the patient's really gnawing at his teeth. He's biting, he's clenching down his teeth. They're holding their arm. They're waiting for pain medicine from the nurse who's in the room. What do I do as a secondary nurse?
Come back when they're finished.
I get the heck out of there. I come back when they're finished. I don't budge in, right? I return when their level of pain is reduced. And why is that? Am I going to get anything out of that interview if they're in pain waiting to take their pill and frustrated because I'm asking them questions?
No.
Like, have you ever had to go through that before? I have. It's annoying, and I just
Yeah.
want to scream. And it's rude. The audacity of me hurting while someone's asking me something stupid about how many kittens or steps I have. Like, nobody cares. Not in that moment. Be respectful. All right, so let's see what else I'm missing here. Sorry, I'm squeaking. My voice is almost done for the evening. Let's talk about protective gear. Let's talk about PPE. If I have a patient who has explosive watery diarrhea, why am I concerned about that?
MRSA or the CETA?
C. diff, not MRSA, close though. C. diff. And what is C. diff?
Oh, it's like it's a contact.
It is definitely contact. You don't want to have a problem with that. So C. diff is a spore, and it is for people who have immunocompromised systems. And a lot of people can get it very quick, and it spreads like wildfire, and you have explosive watery diarrhea until it goes away. And you need a very big host of antibiotics, and it's a big problem in hospitals and ECFs. So we try to keep it down, and it's a big, big problem. Again, if you're immunocompromised, if you're not, it's never a problem. So when you're dealing with a patient with C. diff, you need to make sure that you are covered very well. So what would you assume that you would wear for a C. diff patient?
Gown, gloves, and goggles.
Gloves and goggles.
That's perfect. I love that for you guys. Wonderful. Very good. All right. So tell me about patients in tuberculosis rooms or in COVID rooms. What makes them different?
Is that
They need to have negative pressure.
Yes, they need to have a negative pressure room because we don't want to breathe any of that. What kind of contact precaution is that?
Say,
Droplet.
So it is called a contact plus.
It's droplet.
Yes, a contact plus is a droplet if you mix that with a contact. It's like a step above the worst of the baddies. Okay, so perfect. Let's see. Ooh, let me give you a number and then you tell me what it is rounded to. You ready? 3.14 rounded to the nearest 10th.
3.1.
3.1.
Did anyone say anything different other than 3.1? Okay, good. Ready for another one?
Yeah.
2.874 round to the nearest 100th.
2.9.
2.87.
2.874 rounded to the nearest 100th.
Is it 2.9?
3.
Is it 2.9?
2.87.
It's 2.87.
Is it? Okay. So the first number, the one to the left is the 10th place.
Yes. So I do I have the nursing? How about I go over rounding tomorrow in front of everybody? Because rounding's tricky for a lot of people because rounding is new for a lot of people and that's okay. So how about I add into our mashup tomorrow, me explaining how to do that because it only takes about 30 seconds. So what you would do basically is, what was my number again? 2.9.
2.874.
Got it. So the tens place would be the 8. The hundreds place would be the 7th. The 4th would be the thousands. We're going to look at the hundreds place. So what you do is you go to your number and then you knock next door to the right, and that number is 4. And anything 5 or under, you would not round. So it would just be 2.87. It's going to help you when you write it down while I'm writing it down. So why don't we put a pin in that and we'll get back to that tomorrow. Is that fair? And I'll make sure it's thoroughly explained before you go into exam. Don't worry. You'll be ready for it. All right. So let me give you a scenario and then tell me what's wrong in this picture. So everybody close your eyes so you can paint a picture in your head. I have in my room Sally, who sells seashells by the seashore. She's my patient. And I am coming into the room because I need to do a lung assessment on her. She's here for pneumonia. So I go in and I do my assessment on the lungs. And then when I'm done, I said, Sally, who sells seashells by the seashore, your pneumonia is sounding better. Can I get you anything? She says, no, I'm good. I wash my hands and I leave. What happened wrong?
You didn't wash your hands when you came in?
Boom goes the dynamite. Yep. I should have washed my hands before I listened to those lung sounds the second I walked into the room. Very good. Love it for you. All right. Let's play another scenario. I walk in and I have to fix Sally, who sells seashells by the seashore. I have to go fix her wound. That's pretty nasty. I need to change it a couple of times a day. So I go in and I'm fixing her wound. And as I do that, she says, hey, I can't reach my Sprite. Do you mind giving me a sip? And I go, yeah, sure. I hand her the can, give her a sip, go back to what I'm doing. But I wash my hands before I go back. Where did I go wrong?
Not washing your hands before giving.
Oh my God, is that disgusting or what? I've seen it happen. I've seen it more than once. I've probably seen it over a dozen times. That's insane. Is it not? Yeah. Yeah. I've seen some pretty crazy things. I'm sure you guys have too.
Yeah.
All right. So let's talk about the types of assessment. What's the first stage of an assessment?
Assisting.
There's inspection. What's after inspection? inspection,
Palpation.
good,
Auscultation.
percussion, and
Oh, yeah.
auscultation.
Oh,
Cool.
yeah.
All right. So tell me how I can do inspection on the lungs. How can I inspect lungs?
By looking at them, breathing in them,
Ooh, keep going. What am I inspecting? What am I counting?
The
respiration.
respirations and
Yes, you
how
are counting respiratory rate. Perfect. 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 That is what inspection does. Now let's talk about palpation. What is palpation?
Gee.
You just lightly
the
feel them.
stomach when you're
Checking pulses.
Checking pulses is cool. Feeling for temperature of the client's skin is cool. All those are accurate statements. Love that for you. Tell me about percussion.
You're pressing down. Would checking for edema be like a percussion or no?
No, percussion is going over an organ to hear a difference in tympani to see if there is a presence of dullness or a presence of light and airy, which could be a problem.
Okay.
We're going to percuss tomorrow after the exam. It's a fun thing to do. And it's kind of a wonky thing to do. And it's an old methodology that we used to use back in the day that actually we've been using since the ancients. So it's an old school way of detecting a problem in a patient, and we'll talk about it. But what you need to know is to say rhythmic tapping. Okay, so an example of percussion would be a rhythmic tapping over a sinus cavity to see if it is inflamed. And you'll be able to tell an inflamed sinus cavity because one will sound very hollow and one will sound very tight. And that'll let us know if there's an accumulation of fluid. Does that make sense? Does it make sense?
Kind of.
Here's what you do. Get on your phone, YouTube, percussion, and you'll never do it again. Say percussion over sinus, and you'll never have to worry about what it is again. And we're going to do it tomorrow. We're going to do like a live action percussion on the abdomen. It'll be cool. All right. Tell me about axillary temperatures and why they're kind of shady.
You're like 1 degree off from oral temp or
Good. So if my axilla temperature is 99.8, what's my oral temperature?
is it 100?
100 point what?
8.
100.8.
100.8, yes. If my axillary temp is 99.8, it's going to be 1 degree higher in my mouth. Why is that, Miss Molly? Well, I'm glad you asked because my armpits flap open and shut as I move my arms, and my mouth, when my mouth is shut, it's just nothing but lava lake. That's why. Because we aerate our armpits. All right, give me a normal respiratory rate.
16 to 20.
Try again.
12 to 20.
12 to 20.
That's one good job. Uh-oh, I just had someone ask me my meeting ID. Hang on. This is what happens when I take my phone away. I have 17 messages. Let me make sure it's none of you guys. Sorry. Yep, it is some of you guys. Dadgummit. Okay. All right, good. So 12 to 20. Give me normal blood pressure.
120 to over 80.
120/80, good. Give me normal heart rate.
60 to 100.
60 to 100. Also give me normal blood sugar.
60 to 100.
Okay, very good.
It's 90 to, you said, it's 70 to 90.
60 to 100 is normal glucose. It's going to be different in your hospital because they have higher ranges because they don't want you to dip that low, but a traditional textbook should be 60 to 100 unless it's changed. If it has, let me know. All right. So let's say I have a patient. I'm going to throw off a whole bunch of rando vital signs. You ready? So vital signs are as follows. Heart rate's 100. Respirations are 28. Temperature is 103. Oxygen saturation, 98. So what am I scared of? Why am I scared of it? And what is indicating that that's probably what this is? Or that probably is what this is. Does that make sense?
Mhm.
Okay.
An infection.
Respiratory vital
Infection, how do we know?
Fever.
High.
Fever. And
Fever.
what showed up on the patient in the vital signs that reacted to that fever?
Increased heart rate,
The
respirations.
It was not the heart rate, believe it or not. It was actually the respirations. The respirations will change first on this type of patient. Why? Well, because the whole purpose of the temperature change. Do you know why you have fevers? So that you can bake the infection, and that's how you kill it. It's like killing bed bugs in 105-degree temperature. It's the same concept. That's why you have fevers. And as a result of that, what happens is your body sends a mayday signal that says something's trying to attack you and that you're baking. And as a result of that, you're going to pant like a dog because you're trying to expel heat. You ever notice when a dog gets too hot and it's furry and sunny outside, they start to pant? That's them trying to escape the heat from their body, much like a person with 103-degree fever. Does it all make sense now?
Yes.
Isn't it common sense? I told you, medicine is common sense. It happens all around you all day. You just don't put two and two together. So perfect. You guys have literally answered 218 questions. Can you believe it? This is wonderful. I'm so proud of you guys. So I need for you to know the normal limits of vital signs because I'm going to bring vital signs out and I'm going to need for you to pick the right one. Is that fair?
Right.
Okay. So tell me how to assess a person's pain.
What they say it is?
Yeah.
Rate of pain from 0 to 10.
Yeah. Ask the patient to rate their pain from 0 to 10 that's being experienced by them. It is never our job to say that dude right there is totally okay. They're on the phone, they're text messaging, they're saying they're 10 out of 10. It's bogus. It's a lie. Don't ever do that. And if you ever do it and you have a patient that really has a bad chronic condition, especially like one from childhood, what's the big one that I can think of? Muscular dystrophy is a good example. Those guys, you could have them on drips that would kill an elephant. And they're on TikTok laughing, but they're in excruciating pain because that's how they defend against that pain. That's their defense mechanism, is being overly obnoxious. So you just never know. Don't be ugly to these people. It's real. If they say it's real, it's real. If they're being stupid, we all know those guys happen too. Just you can't separate the two, so don't. All right. Tell me about onset of pain versus location of pain. What does onset mean?
When did it happen? Or what caused it to happen? Is that what you said?
Yeah, onset. What were you doing when it first happened? Perfect. What about location?
Where is it located at?
Where did it happen?
Where did it happen? On your body. Where is the pain? Perfect. Duration. Tell me about duration.
How long?
How long?
How long what?
Did the pain stay there? How long does the pain
How long
last?
have you experienced?
Yes. Yes, characteristics. Tell me about characteristics. What does characteristics mean to you?
How does it feel?
Is the pain sharp? Is the pain dull? Is the pain nagging? Is it waning and waxing? Yes, perfect. All right, A, alleviating factors. We're doing old cart, by the way. We're at A, alleviating factors. So what are alleviating factors? What do we ask?
What
Makes the pain worse or better?
What makes the pain worse or better? I love that for you. That's so great. Okay. R, anybody know what R stands for?
Radiation.
Radiation. Does it radiate anywhere? Perfect.
No.
Go into, do you have a pain that's that's cramping in your right lower quadrant and somehow you feel it in your shoulder blade? Right? What is that specifically? Anyone know what disease that is? Right lower quadrant.
Is it appendix?
It's actually the appendix. Every now and again, you get a rebound pain in your shoulder blades. Yeah, crazy. Very good. All right, so perfect. So for onset, again, what happened when it first started? Oh, I'm sorry, we have T. T, time. Tell me about time.
How long?
What time did you start?
Yeah. How long did it take for the pain to stop? How long is the pain? Very good. All right, so let's say I'm in the birthing center and my bestie is in the birthing center and we plan pregnancies together because that's what besties do. That's weird, by the way. I hope to God I didn't offend anybody by saying that, but that's a lot of prep. Anyways, so I'm over here, Katrina's over there. We're both having beautiful babies and I'm having a 7 out of 7 pain or a 7 out of 10 pain and they're having a 7 out of 10 pain. However, she's in the hall screaming bloody murder, and I'm sitting there casually asking for another cup of ice. What's the difference?
Pain tolerance.
Your tolerance.
Pain tolerance. Whose pain tolerance is lower?
Yours, the one getting the ice.
One that is in 7.
They're both
Well, maybe her,
Is screaming.
the
the one
lowest pain
screaming.
tolerance is the person screaming. They
Yeah.
have a low tolerance to pain. The person chilling like a villain on penicillin, that is a high pain tolerance. That is someone that doesn't feel pain very much at all. Very good. You do need to know the difference because you're going to talk to doctors about this. And if you say it the wrong way, they're not going to give you any more pain meds and you're going to want to know why. I've done that before. It's easy to do. All right. Tell me why chronic pain patients are going to have a lower pain scale rating for pain.
Because
They're used to having that pain.
Yes, yes. That's exactly it. Say that one more time.
Because they're used to having that pain.
Correct. Just like we were talking about earlier. When we were talking about the patient with muscular dystrophy, their pain is going to be a 4 or a 5, and their 4 or 5 is going to be our 10 because patients may not have the same objective responses to chronic pain because of that compensation over time. You're used to that pain over and over. Sickle cell anemia. I had a 21-year-old kid. He literally was on so much morphine. We had to override the override, and we had to have the physician legally sign off on it because this kid just had it so often and was on an ungodly amount of morphine, but needed it just to do simple things like get up and stand and go to the bathroom or eat a meal and have fun with his friends. So remember, these guys are different. We do different things with them. All right, let's talk about Latin. Latin's a big deal to me. All right. You got prefixes, you got suffixes. Tell me what a prefix is. Let me give you a word. Your word is cardiology. What is the prefix of the word cardiology?
Cardi.
Card. What does card mean?
Heart.
Heart. Very good. Very good. Let's see. What if you had follicularitis? What would be your suffix?
Itis.
Itis. What does itis mean?
Inflammation.
Oh my God, you guys are so smart. Inflammation. I love that. Incidentally, tell me what brain means in Latin. What's the word?
This
Céfalo?
Cerebral.
Neuro.
No.
Who said
Yeah.
neuro? I love that for you. Good. Tell me, let's see. Tell me lungs. What is Latin for lungs?
Pulmonary.
Pulmonary. Very nice. Very nice. Tell me, if I tell you hematology, what does hematology mean?
blood.
Blood.
Yeah,
Study
blood.
of the blood.
Okay, so tell me what the prefix is.
Hemat.
Hemat means what?
Blood.
Blood.
Blood. Good. And then ology means
Study
The
of.
study of.
study of. So it's the study of blood. Very good. Very good. All right, so let's talk about positions. So body positions. So I'm standing in front of you in an anatomical position with my palms out because that is anatomical. And I'm going to tell you that my eyebrows are blank to the sides of my face. What is that word going to be that you're going to use?
The segmental. What does it start with an S?
How about I give you some examples? How about I say interior, posterior, superior, lateral?
Superior.
Interior.
Lateral.
Anterior.
Anterior is accurate. The nose is on the anterior aspect of my face, whereas the side of my face is the side of my face. So interior means in front of. So my nose is in front of the side of my face. Does that make sense?
Right.
Yep.
Yeah.
All right, here's another one. I'll make it easy. My badonkadonk is blank to my shoulders.
Posterior.
Posterior. Thank you. I figured I'd make it silly so it would be obvious. Good job. All right. Now, if I were to tell you to lay prone, how are you going to be laying?
On your back.
On your stomach.
On your
Facing
stomach.
down. Facing down.
Oh, facing down.
On your belly,
Facing down.
when you're prone. Is there an easy way to remember that? I'm prone.
Is that the same as prostrate?
What was it?
Is that the same as laying prostrate?
Prostrate? I don't understand. What, did you say prostate?
Prostrate. So in church, they say we lay prostrate. So is that like laying flat?
Spell the word for me.
Maybe I'm not saying it right. No. Okay, skip it.
No, I don't want to, I want to be able to write it down for me tomorrow. Show me tomorrow. Remind me tomorrow because this is curious and this is a word I'm
It's prostrate.
Huh. Lying stretched out on the ground with one's face downward. Technically, that is a prone position by anatomical definition. However, okay, I have a lot to learn. All right, well, that's going to be tonight and what I'm going to be doing until probably 4 a.m. Cool. All right, thank you for that because there is a lot of cultural stuff in between all of that that explains why you do that position. So that's also very curious. Cool. So again, prone is lying on your stomach and then lying on your back would be considered what?
Supine.
Supine.
Supine. Very good. I love that for you. All right, let's do another rounding game and let me make this one easier. Let's 6.73 round to the nearest whole number.
It says so what?
6.
Say that again.
6.73 round
Oh,
to the
7.
nearest whole.
Oh, 7.
7.
Very good. Let's do another one. Let's say let's say I had a bottle of pills and I had 60 tablets in my hand. And let's say that I dropped them, but I dropped half of them. How many is left?
30.
30.
30. Very good. All right. Tell me about risk for abuse regarding elderly patients. What are some signs that someone is being abused if they are elderly?
Fractures.
Fractures on top of fractures that are unhealed. I love that for you. What else?
Like
No.
Unexplained bruising.
Bruising that doesn't make any sense. Like I've got bruises and they're perfectly symmetrical up under the underarm, which is what we always see. And it's 4 perfect prints and a thumbprint on the opposite end. I swear to God, it's always that way. That's a classic sign. Good. Tell me about dependence with family members.
Is it
Missing items could be of
money?
financial abuse.
their finances?
Yeah. Yeah. The patient is completely dependent on that family member for food, for medicine, for financial resources. So they're terrified to speak against them. Have you guys ever met a patient that fit this mold?
Yes.
Yes.
Yeah. All right, hang on. I still can't get Skylar on. Guys, what's my meeting ID number? 973-907-2298. Is that right?
Mm,
Or is it 937?
973-907-2298.
Cool. Hang on. Sorry, we don't leave anybody behind. That's my rule. Even if we have to go slower. Okay. Does anybody have a relationship with our friend and maybe can help them get into the meeting even though it's almost over? I did record. Hopefully it's going to post in the next hour or so, but I can't promise anything. If you guys can work on that while I continue. So again, going back to the elderly, we need to make sure that we're watching out to see if they have these signs of abuse. And again, another one is being terrified of this family member speaking ill on their behalf. Another classic sign is if they call and they miss that call, then they start calling up at the nurse's station, yelling at us. That's another indicator of abuse, because if they don't get that immediate answer, they want to know why no one's checked on them and they're not getting adequate care. So just be really, really, really careful with these guys because they all fit this kind of textbook mold, right? Which is why we teach you about these things and why we make it part of your examination material. All right, so let's talk about blood pressures. Let's say that I took a blood pressure on one of the arms and I get a blood pressure reading on my Dynamap of, I don't know, 225 over 115. All right. What's the absolute next thing that I do as a nurse?
Recheck the blood pressure.
In what arm?
Wait 5 minutes and
Yeah.
then on the next, on the other arm.
Correct. Check the blood pressure on the opposite arm. Why?
Just to make sure it's accurate.
To make sure that it's accurate. Yeah, that's good. Now, incidentally, don't forget, if you have a big variance of blood pressure on both of your arms, that is an indicator for a subclavian occlusion or clot, and that's a big deal. So you have to be aware of this. And if you do have a variance that's like 200 systolic on one side and then like 150 on the other side, that's a direct indicator of that problem. So you need to immediately notify a physician if you see that. But indirectly, if we throw a cuff on a person and they ring that high, and I look at the patient and I can see clearly the patient doesn't have a headache, isn't giving me any indicator, isn't flushed, isn't doing anything, the first thing I'm going to do is check on the opposite arm. Very good. All right. Let's say that I am making a tincture. What is a tincture, guys? Tell me what a tincture is.
Oh, I don't
A
know.
tincture is an old word for mixing two things together to make something. All right, so a tincture is Kool-Aid. I don't know about you guys, but I grew up on purple Kool-Aid. It wasn't grape, it was purple. It was a big deal. All right, and in my Kool-Aid, you had to first make simple syrup or your Kool-Aid was no good. And we didn't go to your house and you were embarrassed. So you make your simple syrup, and then once you've done your simple syrup and it's sat in the hot water and it's diluted down, then you put in your little packet and then you put your water over top of it, right? This is the concept of layering and making tinctures and medication. Now, why is that important? It's important because now that I've picked that in your head and that's the memory you have, I want you to tell me if there is 10 milligrams of medication in 100 milliliters of fluid, then that would mean there's how many milligrams of medication in 200 milliliters of fluid?
20.
20.
20. Does everybody understand why it's 20?
I need you to
Because it's
repeat
double.
this. I don't know.
So
Mhm.
I'm going to explain this one tomorrow, so don't get frustrated. It's okay. Basically, what you're doing is you're comparing and contrasting two products. You're comparing and contrasting your sugar for your Kool-Aid to your fluid. Does that make sense?
Mhm.
That's all you're doing. So if I got a packet of Kool-Aid that's got 10 milligrams of Kool-Aid in it, and I use 100 milliliters of water, then that would mean I would need how many Kool-Aid packets to do 200 milliliters of water?
2.
I need 2. There you go. Same deal. And then what's the milligram of those 2 packets if they're 10 milligrams apiece?
10.
10 milligrams in 100.
10 milligrams in 100. So 200 is going to have how many?
20.
20. That's it. That's all there is. That's easy, right? No tricks. It's easy, easy peasy lemon squeezy. Y'all got that? I'm not here to hurt you. I'm here to love you and show you what it is to be a part of this family. This is very much a family. We depend on each other. We take care of each other. If anything ever happens to you, you need to let me know. Do you guys know that? I say that because I got a call from one of my students who is with child and unfortunately homeless. Right? Like that's a call I just got an hour ago. So you guys need to know I'm here to take care of you. I'm here to spread joy. I'm here to teach you a lot. You guys tonight have answered over 270 questions that I've asked you at random, and you've done it with nearly 100% excellence. How do you think tomorrow's going to go, guys?
Collard greens, macaroni, and fried chicken.
Girl. And the best daggone cookout I done ever had. I'm just saying, there is no witchery, there is no trickery. I literally have taught you that much by not teaching you anything. Do you see how that just happened? Isn't that beautiful?
Mhm.
This is how I teach you nursing. Please trust and believe. Whatever you think about me right now, after tomorrow, I promise you, you won't think the same. Unless you didn't study, and then you're in a lot of trouble. But tomorrow's going to go exceptionally well because you have learned a lot, and you should be very proud of all of the things that you have just learned. You've learned more in 3 weeks of quote unquote no lecture because, again, third week we're taking an exam. First week we're talking about the syllabus. Second week, I kind of had something going on. Apologies, but it's all there. You guys have learned more in that 3 weeks of never having a class day with you than you will sometimes learn in an entire elective class. You should be very proud. I've taught you some very hard things and I've done it under the sly. It's not been easy, but you've done it. Tomorrow's going to be good. What questions can I answer for you right now before we go for the evening?
I have one. Just going back to the PPE, when I said droplet, you said contact plus. Is that what they refer to it now? Because I haven't heard that term before.
Contact plus is what they refer to it post-COVID. Okay.
Okay.
So contact plus precautions. Vancouver Coastal Health got with the World Health Organization and they produced a contact plus precaution, which also encourages families and visitors to stop and report to the nurses before staffing. So yeah, it's just a fancier word for a secondary heightened level that's scarier than scary. Remember back in the Bush administration, senior not junior, we had the levels of terrorist attacks. It went from like green to like red, and then at random it would change colors, and we'd be like, should we be worried or not? It's kind of the same thing. Does that make sense?
Yeah. Do you think so we would see contact plus in our like HESIs and our NCLEX and stuff like that now post COVID?
I mentioned Contact Plus. Otherwise, I wouldn't, because Contact Plus is another derivative that comes up on these HESIs and that comes up on the NCLEX that might be a new way of understanding it. However, I'm not looking at your NCLEX books, so I don't know if they introduced Contact Plus because it was just a COVID thing.
Okay. Yeah, I was just like, what if they gave us like both?
They wouldn't, because they know that they're the same.
Okay.
Yeah.
Thank you.
So I know you're fine. Don't worry about it. What happened was is we didn't know what COVID was when COVID happened. And at one point we all thought we were going to die, if I'm honest. And it was supposed to be the highest alert. And we didn't have a way to establish it because there weren't enough people to establish it. So when it happened, and it was happening by the millions, we kind of created it. Does that make sense? Because Contact Plus is, I don't know what the heck this is, and until I find out, no one's getting in, no one's coming out, everyone's locked down tight. Does that make sense? Hopefully that makes sense. Hopefully I didn't confuse you. We're not going to use Contact Plus for this examination or any others that I'm aware of for my class, but I throw it out there for the NCLEX reason. Cool. Any other questions?
Yes.
Okay.
Can you explain what negative pressure is?
Yeah, negative pressure is when it sucks the air out of the room and pushes it out into the atmosphere through filtration. So what it is it is a suction vacuum hose, much like, ooh, how about this? The silver hose on the back of your dryer. Same concept. That would be considered a negative pressure system. It is a closed loop where all of the aeration from the dryer is exited out and it does not go into my space. Does that make sense?
Yes.
Okay. So therefore it cannot go out into the hallway. It's simply sucked back outside.
Okay.
Questions?
What about completing a monthly breast self-examination over 40? Is that secondary or primary?
That would be secondary, because as we age, the potential increases. So again, we're walking a tight wire of I don't have it yet, but it is in the lifeline. Does that make sense?
Yes. That's most definitely. Okay.
So a mammography will be secondary as well.
Mammography will be considered secondary, correct? Because I wouldn't ask a 20-year-old who didn't have a history to do mammography monthly. But once they hit that age bracket where they get into a threshold of being at higher risk then puts them from a primary position to a secondary position, because now they have a contributing factor. Does that make sense?
Yeah.
Okay. You guys are going to be okay. You know that, right? Do you guys know how smart you are?
Yes.
You guys know this stuff. You answered all of my questions.
I have a question. Are we supposed to download the exam on Exemplify?
You can download the exam now, yes, but I have to give you a code for you to be able to do it, and I'm not
Right,
going to
yes,
tomorrow.
okay.
So download it now so it's easier, and then we won't run into so many bumps in the road tomorrow.
Okay.
Any other questions? All right, my friends, I want you to get a good night's sleep. Everything's going to go well. I just saw the chat box because I'm on the other end. Hopefully there's no questions in here. I don't see any in here. All right, cool. So you guys go to bed, get some good sleep. If you want to ask me anything tomorrow, I'm going to be up at an ungodly early hour, probably 6 or 7. You can always shoot me a text, but not in the next couple of hours because I like to at least sleep and try to get rid of some of the sickness I have because I feel like crap. But other than that, I'll see you tomorrow. It's going to be fine, guys. You're going to do great. I'm really proud of everybody.
Thank you.
Thank you.
Thank you. Good night, everyone.
Thank you. Good night.